Okay, good morning, everyone. Sorry about that. We just came off another meeting, so we are slightly delayed, and I apologize for that. But I wanted to welcome you all to this month's quarterly staff meeting. Chris Spidel is not here, so I will be uh, running the meeting today. For those of you that do not know me, my name is Dinesh Gangasingh. I am the president-elect of the medical staff, and I am an anesthesiologist here at Missouri Baptist for the past 15 years. So welcome, everyone. The first order of business is to approve the minutes from January. And as it flashes across your screen, so unless there are objections, in which case I would expect to see hands raised, the minutes will be passed unless I see hands raised to object to it. Okay, well, I don't see any hands, so that's a good thing. The next order of business is to welcome the new staff to Missouri Baptist. And as you can see from the screen there are quite a few staff members. So I would like to welcome each and every one of them. In the past, you would stand up, you'd be acknowledged personally, but because of the virtual meeting, we will just flash your name across and say welcome to you. The next item on the agenda is actually the physician acknowledgement, physician recognition. There are two physicians that we are recognizing today. One is Jeremy Defoe for his exceptional work and hard work in the COVID ICU, as well as his extra campus work. As you can see there, he goes in above and beyond suturing outside of the clinic. So Jeremy, congratulations and job well done. The next physician is Dr. Susi. He's an orthopedic surgeon that has been with us on and off for the past few years. Most recently, full-time with Missouri Baptist, going above and beyond what was expected of him, spending a considerable amount of time taking care of a patient that was ill outside of his comfort zone. So Dr. Susi, we thank you very much for your service. The next order of business would be introducing the Joe Anstey Award, and I think Ben is going to talk a bit more about the award and who's going to receive it. Dr. Voss?
Yeah, good morning, everyone. Dinesh, thanks for having me. So as part of our Physician Wellness Committee and Burnout Prevention, for years we've given away the monthly awards to people like Dr. Susi and Dr. Defoe as a thank you for your hard work. And then this year with COVID and all the extraordinary challenges and opportunities it presented, we decided to implement a more formal annual award, kind of a bigger deal basically. And at that time, we thought of nobody better to name it after than Joe Anstey. Joe is a MOBAP legend and recently passed away, as we all know, from cancer. And Joe just embodied all the clinical excellence that physicians and nurses and staff at MOBAP have done for so many years. So in recognition of clinical excellence, the MEC took nominations and voted and awarded it to Dr. Michael Fuller, who Mike did pretty much everything during COVID. So thank you, Mike, again. He worked in the COVID ICU. He worked in the respiratory clinic. He helped the hospitalists with overflow, even on weekends and holidays. Really did an incredible job with end-of-life discussions with patients that we didn't know on 4 West and their families, and even continued to volunteer at Casa de Salud. So Mike did so much. It was a really wonderful presentation we gave with Chris and Mitch's support. We had a lot of people on teams and family and office staff present. So it was really great. So thank you, Mike. And there's a second plaque now hanging in the doctor's dining area that will have the annual award recipient listed there. So it says 2020 Mike Fuller. And at the conclusion of this year, we'll take nominations and vote for the 2021 winner. So congratulations. And the Physician Wellness Committee continues to do our best to promote wellness and also help with things like EPIC repersonalization labs, so please feel free to sign up for those. We now have midday mindfulness, so you can sign on at 12:10 daily to have a meditation mindfulness instruction, which is great to take a pause over lunch. And then we continue with our Project Unplugged enrollment, which we're on our 7th cohort now, right down the road at Longview Farm Park. So a lot of opportunities for physician wellness and burnout prevention. If anyone's interested, please text or email me and I will get you plugged in. So thank you very much, and congrats to Mike Fuller again.
Thanks, Ben, and congrats, Mike. Great job. Keep it up, and you're a great role model. The next part of the meeting is going to be divided up into 4 sections. We're going to have updates from different departments regarding issues that are very pertinent to us. So the first of these is going to be Dr. Reuter with the secure chat feature. Matt, take it away.
Thank you, Dinesh. So I'm not technologically savvy, but my job here is to show you that secure chat is actually better than text messaging. So I can't do a real live demo because that would be the best way to convince you, but I'm going to walk through some ideas of how we can make this technology work better for you. So as physicians at Missouri Baptist, we've had this at our disposal since September of 2020. It's the last time I spoke with all of you, and it's actually something that's available for every single physician throughout BJC. However, what has happened within the past 2 months is now that every single user throughout BJC, including your nursing staff, your case managers, your pharmacists, anybody can send and receive a secure chat message. So hopefully, despite this hasn't been terribly disruptive to all of you. There have been a lot of steps taken place to create some guardrails. So I'm here to take the fear away and encourage you to try this tool. The first thing you need to know is this is something that's on a phone. It's called Haiku on your phone, and it is very similar to sending a text message. But it has a significant advantage, is that it will actually attach a patient to that record and that message, so that if you were to consult somebody and link that patient, they don't have to write down the name of that patient, worry about misspelling, trying to find that piece of paper and pen when they're in a car or off campus. This message is going directly to your phone and will be saved there. It will be one click away that you can get inside that medical record, see the laboratory values, imaging results, and the last progress note, or any note for that matter. So another advantage of this tool is it's faster than loading Epic on your desktop. If you are remote, everybody knows how you have to use your Imprivata ID or Duo, and it can take several minutes to log in remotely. This, you log in once a day with your password. It's going to recognize your thumb or your Face ID, or I guess your Retina display throughout the rest of the day, so you can get in the chart pretty darn quickly. And it works a lot like text messaging. If you get a text, it's going to beep. You're going to have a little bubble in the upper left-hand corner, those red bubbles, and show that you have a new message. So next screen. So what I encourage you to do now that you have Haiku on your phone, and if you don't know how to do that, please go talk with CIS. I'm happy to help show you, but there are some handouts that are going to be a lot more detailed than what I'm sharing with you this morning. This is really intended to be more of a practical application of how this would look to you, and it is a very intuitive program. So when you open up Secure Chat, and if you see on the bottom bar, it's the 4th button over, it's highlighted in blue. If you go up to the top, this shows your availability. Next slide, please. You click on set your availability, which would be the default, and if you look on the right, you have 3 different choices: available, busy, or unavailable. And I've seen a lot of you do this, especially those of you who may be in the cath lab or GI suite or surgery, where you not only click that you're busy, but you give some type of message in terms of what you're doing. I'm not going to tell you how you add that additional message, but it is pretty easy and straightforward. I encourage you to put available if you are available. One of the guardrails is that nursing staff should not be contacting you after 7 p.m. We've encouraged this to be a 7 a.m. to 7 p.m. tool, so you don't necessarily need to change your availability after 7 p.m. One thing I would discourage is setting your unavailability for 6 months or so. If you're on vacation, please do so. you're going to get messages whether you put yourself unavailable or not. But if I see you in the hallway and then, you know, I look and see that you're unavailable on a regular basis, I'm going to wonder why. This helps people know that you're physically here, that you can take consults. It's a much easier and quicker way and compliant way to communicate these messages. So please set your availability in the morning. That is what nursing staff is being told to look for. If they aren't available, they will not communicate with you. And I would suggest that it gives peace of mind to the patients and the nurses that they can reach the physician pretty quickly and promptly. If you allow secure chat, they can also add a message that doesn't necessarily need a response. It may need an action from you, but it is something that may actually be a time saver than having to take that phone call or return that phone call and go through Vocera and wait a ton of time. This is a technology that could work for you if you lean into it. Next slide, please. So this essentially is a reminder that nursing staff should not be messaging 7 p to 7 a.m. This is a new tool for everybody. This is the future really of BJC. This is the primary communication tool that we are looking for. This is a Missouri Baptist policy, 7 p.m. to 7 a.m. Feel free to educate the nurse in a nice manner if they do reach you after hours. If it is an ongoing issue, please escalate to me or your division or department chief. Next slide, please. So you got Haiku on your phone. Oh. You've updated your availability. This is what you do if you want to send a message. And maybe this is a patient you just saw, you did a note on, and you know you need to communicate back to the person who consulted you, or you want to put a new consult in. Chances are you've already opened this patient on your desktop, and you can do the same type of thing from the desktop. This is not something you just have to do with the cell phone. But I'm going to show you how you attach a patient and recognize if that message has been seen. Next slide, please. So bear with me on this slide. There's a lot of arrows and hopefully it doesn't make you dizzy looking at this. But the key is that you need to select a patient. That's going to make the conversation and the flow of communication much easier, as the recipient can access that chart with one click if you do so. So you certainly could type in that patient's name, but I'd encourage you to look at these plus signs on the right. These are there to make your life easier. If you were to click on the plus sign for patient, it's going to give you a list of patients that you've opened their charts very recently, and it may just require one click beyond that rather than trying to type a name and potentially misspell their name and struggle. Or there may be patients with same names but different date of birth. It's going to make your life a lot easier if you use the plus sign. You can also hit the plus sign for who you want to send the message to. If somebody is part of the treatment team, such as a nurse or another physician, chances are if you click this, their names are going to pop up as one of the options you can select. Alternatively, if you have an APP or a colleague that you frequently message, I encourage you to do what this green arrow shows you to do, which is make them a favorite. So I have my office manager and a couple APPs I commonly work with as favorites. All you need to do is click on the star next to their name. That'll shoot them up to the top of the list. You don't need to go typing their name and searching all over the place. One other cool thing that I discovered in preparation for this talk is this I button, the I with the circle. If you need to call somebody, because certainly secure chat is just a tool. It's not the only way to communicate, but it's something that's there to make your life easier and make communication easier. Click on the information or I button and it will pull up a phone number for that provider and address that may be helpful, assuming the cell phone is saved within Epic. Next slide, please. So I've already said one of the best uses for secure chat is for your routine consults. Your urgent emergent phone calls really should require urgent and emergent consults would require a phone call in addition to any type of communication you sent. Driver, get back on the road. So What the other most common use is if you are going to have a group conversation. So remember the communication seminars that Mitch set up several years ago. We had one where there were 4 different consultants on the case, and the perception of the patient is nobody was talking. So the second great use is if you're having a group discussion on a complex patient where you need to pull everybody together. Maybe that's coming at a big decision point during the case, or if you're doing discharge planning. What you can also tell is who's seen your message, because that's another huge advantage beyond that makes this a better tool than just text messaging. So number one, it's better because you can see that patient name attached, 1 click and you're in the chart. Number two, you're not sending a message or a phone call and wondering if that other person is seeing it. Maybe you got the wrong phone number, maybe they're out of town. You have a little icon underneath your message, and I'm pointing to it with the blue arrow that says seen. So I know that this nurse has seen that message. If you look at the next one down, I have multiple physicians on this thread, and it'll actually change to seen by all. And if there is a large group, and certainly it's not going to be seen by all at some given time, it'll actually update. It'll say seen by 1, seen by 2, seen by 3, until everybody has seen that message. So it communicates back to the sender without the recipient actually doing anything. And you can't assume that they're going to do something and they're going to acknowledge that note, but there's a good reason to believe that if you're sending it to a physician, they are going to receive that consult. They're going to be aware of the communication. Certainly, if you see that it's not unseen, it's going to require you to communicate in a different fashion. Next slide. So this is very, very brief, very high level. There's a lot better literature if you want to figure out in more detail how to do different things, attach pictures, remove yourself from the conversation, which if you're part of a large group and you're really not part of that conversation, maybe that's something you want to do. But I encourage you to get this tool on your phone. It's called Haiku. It's very easy to download through the App Store, and experiment and educate for yourself. You can find the care team within the patient's chart and figure out a much quicker way to message somebody if you are on the desktop. On the phone, you can actually enter orders, and it's, again, I'm not terribly technologically savvy, but this is very, very easy and straightforward. And some things you cannot give orders for. You can't give any order actually by secure chat. But if you do get a note from a nurse or somebody's requesting something, it is very, very simple, and you don't have that long login like you would with a desktop to put in an order. And you can do it yourself. You're not relying on the nurse and having to explain things or risk that something is lost in translation. If you are out of town, or maybe you're in a procedure tied up for a few hours or so, and you want to forward your messages to a colleague or an APP so they can take your messages, you can do that. You're still going to get those messages to your phone, but it will allow timely responsiveness to whoever's asking for your services that hopefully your colleague or APP can help you. And there's probably a ton more this tool can do. Once you're in a patient chart, look at the bottom row and play around with it. I think you're going to find a lot that you could get overwhelmed with, but there's some simple things. Find 1 or 2 things that you like. And I think you can learn a lot more and probably even teach the rest of us. But I'm just sharing a couple of the high level things that I think are very important, because I am more and more convinced that this is a superior tool to communicate than text messaging. HCAHPS, patient satisfaction, they're all dependent on good communication by our physician staff. We're the leaders of how we communicate, and it's not the only way, but it is a good way to make you less insane. Certainly when you get phone calls throughout the day, it interrupts your workflow. This is a way that you can separate your work life a little bit if all your messages start flowing to Epic, and you can open this message at an appropriate time, recognizing this is not something that needs to be opened immediately, but the idea is that you're going to be able to open it maybe in the next 30 minutes, 60 minutes, but it will get some attention. So try it out. Thank you very much.
Thanks, Matt. I just want to reemphasize that Haiku is the mobile version the slimmed down version of the Epic desktop. The secure chat feature is not to be used for entering orders. I just want to make that clear because the last bullet point felt a little muddled that you could enter orders with the chat. You cannot enter orders with the chat. We'll take questions at the end. If you guys can save them if you have any. The next update is going to be from Dr. Nitin Anand about the COVID update. Doctor.
Thank you. Next slide. What a difference a year makes. Ben Voss actually texted me a photograph last night from the COVID ICU. I think it was one of those iPhone memories. And in it, he and Beth Conradi were actually listening to me as I had something to say. A year ago, we were afraid. We didn't know how the virus spread, and we didn't have good treatments. But a year later, we're in a much better place. You can see from these numbers in April of last year, our numbers were actually probably spuriously low because of our limitations in testing. And then we had a huge surge during the winter months. And now I'm happy to report that our numbers throughout St. Louis, Missouri, and BJC, we actually have the lowest admissions that we've had throughout the entire pandemic. Next slide. Why is this the case? It's because of a triumph of the biopharma. And who would have thought that with mRNA technology, we could have created a vaccine in just 1 year? The United States is vaccinating between 4 to 5 million people every single day now, and Missouri is also proportionally vaccinating that much. Right now, as we've heard in the news, it's really a race between the variants and the vaccine. I truly believe that we won't have a situation like they currently have in Michigan with B117 because of our pace of vaccines. As you can see, almost 50% of adults within the US and Missouri now have received 1 dose of vaccine. So 3 weeks from now, that will mean 40 to 50% of patients are fully vaccinated. If you add the 10% of patients who have been proven to have COVID-19, and another 10% who probably didn't have it, that means 70% of us probably have some immune protection against the virus. Next slide. Now, why have outcomes improved? Certainly, some of it is because we're seeing younger patients being admitted to the hospital. But I'd also argue that some of it is because of our improved treatments and improved understanding of the disease. These are rolling totals of patients being admitted. And you can see that from the last time I reported to you, 4%, our percent alive at the time of discharge has improved by 4%. And at Missouri Baptist, it's improved by 5%. I don't have the previous comparisons for the ICU, but 63% of the patients who have been sick enough to enter our ICU have survived. And that doesn't take into account all of the patients. We've been receiving the sickest of the patients throughout the pandemic of being transferred to our ICU. So it's remarkable to think that 63% of those patients have survived. And of those that went on to be ventilated, greater than a third have survived. Next slide. Next slide. All right, it looks like it's frozen. But one of the paradigms of critical care is this arch of critical illness. And anytime, the way to think of this is on the ascent of the arch. That's when you're administering early and aggressive treatment. So for heart disease, it means early coronary revascularization. For sepsis, it means antibiotics and resuscitation. For stroke, it means thrombolytics. Then the top of the arch is when the patient begins to improve. And then the descending portion of the arch is you take away the ICU support as quickly as possible, meaning you take away the sedation, you take away the ventilator, you remove the Foley catheters, you remove the lines. And it's been proven throughout the critical care literature that the narrower the base of the arch leads to improved mortality, improved cognitive and functional outcome, decreased length of stay, and improved cost. Next slide. So what does early and aggressive treatment look like for COVID? Early on, we focus on antivirals and boosting the immune system. So by early, I mean less than 7 days before our bodies had a chance to develop antibodies. But for outpatients now, we're consistently giving the Regeneron product throughout BJC for those patients highest at risk for developing more severe disease. Remdesivir is the antiviral, and Merck is currently developing an oral antiviral, which means that a lot of these patients will be able to receive antivirals as soon as they're diagnosed as outpatients. The late treatment of the disease focuses on anti-inflammatories. So from the recovery trial, we had Decadron, which improved mortality. And recently, and I'll direct you to the February New England Journal of Medicine, we've introduced tocilizumab, which is an anti-IL-6. So the thought is that you're reducing the inflammation that the virus causes throughout the body. And tocilizumab was also shown to be a benefit in the REMAP-CAP study as well as the recovery trial. Next slide. So throughout the pandemic, I've asked my team to focus on the recoveries, and that was to boost morale and to, frankly, for our sanity. Next slide. But 1 year on, we must also be humble and recognize those people we've lost. Just from April 2020, I remember a middle school teacher who came into our ICU. She was a librarian, and she was a harbinger that we had community spread within St. Louis. We remember a patient who was in her 30s and who had 3 young kids, and that loss devastated our staff. And lastly, there was a gentleman who returned from the airport after a vacation in the Caribbean. I remember calling his wife the next day, and she said, I didn't go on vacation with him. It turned out he'd gone with his mistress. These were people who were just living their everyday lives, and we must recognize that we've lost so many and that we could have done better. Next slide. America has lost more deaths from this pandemic than any other nation, and that's despite the fact that we spend more on healthcare than anywhere else. And while this may reflect on failures in public health and preventative care, we must recognize that we could have and should do also better within inpatient care and the ICU. And that's why, you know, I used to play poker, so I'm going all in with the BJC Critical Care Council. Healthcare is ripe for innovation and transformation, and we have to embrace it. I envision a time when technology doesn't burden us, but rather frees us up to do tasks like communication and bedside care. There has to be a time where artificial intelligence and machine learning is able to perform routine and data-driven tasks and allows us to take better care of patients. But to get to that point, you know, that St. Louis arch that I was talking about, not everyone calls it a St. Louis arch of critical care, but I think there's consensus within the critical care community that is evidence and that's the best care of the patient. However, we don't consistently apply it even within our hospitals within BJC. So while there may be a debate between personalization and protocolization, we have to admit that somewhere there is a need for standardization, and that's what the Critical Care Council is trying to do. We'll only get the help of technology and machine learning if we become somewhat consistent in the lowest denominator of basics of critical care and hospital care that the machines can learn. So that's the focus of my work now. Thank you.
Thank you, Nitin. Yes, we have come a long way. Chris Thornton, you're going to present the radiology update for us.
Thanks, Dinesh. Just going to give a quick update on the Department of Radiology and the things that are happening. Next slide.
Chris, if you're speaking, we can't hear you. Still can't hear you.
Can you hear me now?
That's better.
My apologies. BJC Ellisville opened February 1st, and our operating hours are 8 a.m. to 4:30 p.m. For anyone who has patients near the Clarkson-Clayton area, we'd be happy to perform their screening mammograms, ultrasounds, diagnostic services, and bone densities. Next slide, please. So this is a picture near the emergency department. I think everyone has noticed the big tent. What's housed in that big tent is a mobile MR unit to give us a total of 4 MR units currently. We're projecting construction for 2 new MR units to begin by the summer with a completion date by the end of 2021. That will give us 2 3 Tesla and 2 1.5 Tesla MR units. Once that construction begins, you will likely see that tent move places. The mobile unit will have to relocate. Next slide, please. So we implemented a new PACS system at Missouri Baptist on February 27th. This is a system-wide PACS system. PACS is how the radiologists and the surgeons in the ORs view their images. And we were the 4th, I believe, currently live with this Sectra PACS system. Our BJH, Children's Hospital, Missouri Baptist, Barnes West, with recent additions of Progress West and Barnes St. Peter's. Christian Hospital and Parkland are slated to go next and later this month. Next slide, please. So over the last year, we've gotten a lot of requests to have our teleradiology reports uploaded into the Epic EMR. And I am guaranteed that this build will be completed by June 1st. So currently VRAD is our teleradiology provider providing preliminary reports overnight, and they will be uploaded into Epic by June 1st. Next slide, please. As most of you know, we transitioned to Washington University on March 1st. The leadership is remaining the same. We've onboarded over 80 radiologists, and current services remain unchanged. Next slide, please. You may see a few new faces in interventional radiology. A few faces you may recognize. Floyd Scales, who has been with us for quite a while. Floyd is going to stay with us through the end of July, at which time he plans on retiring. John Caragiorgio is back with us. Jim Duncan is the chief of IR, and I wanted to introduce Christy Cruiser. If you haven't had a chance to meet her, she's the physician assistant in interventional radiology, and she's at Missouri Baptist 5 days a week and a great resource for collaboration. Next slide, please. So how to communicate with the radiologists, with the onboarding of 80 new radiologists. I've been getting this question quite a bit, and to piggyback off of Matt's Epic Secure Chat, I think Epic Secure Chat is a great way to communicate with the radiologists if it's non-emergent and you can wait a couple of days potentially for a response. Then we'll talk about the MBMC physician directory, and I'll introduce 2 new radiology assistants. Next slide. So Epic Secure Chat, I'm not going to go into the detail that Matt did, but basically all of the radiologists who have been onboarded, if you had a specific question regarding something that was in the interpretation of a case, and you can just search that physician, attach the patient chart, and send them a message asking your question and maybe get clarification on something. Next slide. So the MBMC physician directory is something we have that we've utilized for years in radiology. If you are on staff at Missouri Baptist, you are in this directory, and it's a great directory for us. If you don't have this on your laptops or desktops at your place of work, please reach out to Katie Nash or David Owens, and they'll help you get this link and put it on your computer. But basically, this would be for if you had a question that, maybe the patient's in the office and you need this question answered immediately, and you can search the physician name. In this case, I chose Sanjeev Bala, and you can see that the patient or that the physician information, including the cell phone number, is there, and you can reach out to them, and that's a quick way of reaching us. Next slide, please. A couple of new faces in our department, and their offices are in our back hallways. We have an administrative assistant, Janetta Paris, and an imaging assistant, Aaron Seymour. So if you had a more basic question regarding, let's say, an MRI of the abdomen and what's the best test order, you might reach out to Janetta Paris, and she would be able to plug you into someone who's going to answer that question quickly. I'm happy, if you aren't able to screenshot these numbers or to get these to you. Next, please. So in summary, we've had a lot going on. BJC Ellisville is now open. We're going to start that fourth, 2 additional 3T or 2 additional MR units. Our enterprise packs went live February 27th, and then we're going to have that Epic report integration. And of course, we transitioned to WashU. So it's all been a very busy and positive month for radiology. And if you have any questions or just want to stop by, I'm typically sitting in my office, or I'm certainly always available via cell phone. Thank you.
Thanks, Chris. Again, if you have any questions, we will address those at the end of the session. Next up is Dr. Rhonda Cook. She's going to bring us up to speed with the high sensitivity TROP-T testing at Missouri Baptist. Rhonda.
Thank you. We went live with high sensitivity troponin on March 3rd. We know that chest pain is a common presentation in the emergency department. Go ahead to the next slide, Alejandra. And even though most patients will not be diagnosed with an acute MI, figuring out who's at risk for acute coronary syndrome is critically important. In our laboratory efforts to aid diagnosis, Missouri Baptist went live with 5th generation troponin about 5 weeks ago. This test has some advantages over our previous troponin test. Because high sensitivity troponin assays detect early low-level troponin release, they may permit a shorter interval between troponin measurements. At MOBAP, we have reduced our interval to 2 hours from 3. And using high sensitivity assays, troponin from injured myocardium will be detectable on initial sampling or repeat testing in as little as 1 hour after ED arrival. For patients with no other concerning factors, low-risk patients, in other words, some centers are ruling out patients based on a single high-sensitivity troponin below the level of detection. Our laboratory offers 2 tests for your use. Lab 5991 is a single troponin measurement, and we have a series with draws at baseline, 2, 4, and 6 hours, which is called Lab 6027, for your use as well. In addition, the standardized troponin testing across BJC ensures that all of our facilities are using the most sensitive assay. Next slide. The switch to 5th generation troponin brought a lot of changes. We have new units of measure. Those have changed to nanograms per liter. We have different draw intervals, which I've already mentioned. We have gender-specific reference ranges and even new critical values. You can see that now male patients have a reference interval of less than or equal to 22 nanograms per liter, and that number is even lower for our female patients of less than or equal to 14 nanograms per liter. We have multiple critical values for troponin. One is when the result is greater than 200 nanograms per liter, and we have other critical values that are based on the delta values or absolute values of the troponin measurements. Next slide. Detection of an elevated high sensitivity troponin value above the 99th percentile upper reference limit is defined as myocardial injury, and the injury is considered acute if there is rise and fall of the troponin values. That's what we are calling the delta value. And the delta is always compared to the baseline draw. Next slide. Yeah, there we go. So this gives you, in a very small space, not only the high sensitivity troponin algorithm, but the delta and absolute values that result in insignificant, equivocal, and significant findings. Currently, we have a number of critical values. I mentioned when the absolute is greater than 200, and then also when these delta changes occur or the interpretation of the testing is significant. There is discussion within BJC about reducing or even eliminating critical values for troponin. Dr. Mitch Scott, who was instrumental in developing this algorithm, he is one of the clinical chemistry directors at BJH, found in an investigation that less than half of hospitals have critical values for troponin, and so those talks within BJC are ongoing. The confusion comes about when the findings for high sensitivity troponin are not consistent with an MI. Next slide. We know that other conditions cause elevations in troponin, and these may be very challenging to diagnose. Many more individuals will have chronic elevations of high sensitivity troponin, especially those with underlying heart disease. But lots of conditions can cause these elevations. You can see that some of them are listed here on this slide. Diabetes, left ventricular hypertrophy, chronic heart failure, and renal insufficiency have all been associated with elevated troponin, underscoring the challenges of diagnosis. Even endotoxin-mediated sepsis can cause elevated troponin values, with myocardial function recovering completely once sepsis is treated. Elevated high-sensitivity troponin represents myocardial necrosis, but doesn't indicate a specific etiology. In other words, it tells you what, but not why. Even when acute coronary syndrome is absent, elevated troponin still represents underlying myocardial injury and an increased risk of an adverse outcome. Next slide. This is the classic scenario of a patient who has myocardial injury of unknown etiology. Troponin testing is above the reference interval but below the critical value and relatively stable. If the troponin level does not change significantly over time, these elevations may result from a newly diagnosed yet chronic condition such as those I've already mentioned. Elevations may represent acute but non-coronary artery disease-based conditions that are causing myocardial damage, such as myocarditis or pulmonary embolism. For some patients in whom an etiology cannot be established on initial assessment, further investigation for coronary artery disease may be warranted. Previous studies have shown that with implementation of high-sensitivity troponin, patients with minor elevations that would not have been identified with our older assays more often receive cardiology referral, dual antiplatelet therapy, statins, and coronary angiography. And this more aggressive approach has been associated with a significant decrease in mortality and acute myocardial infarction at 30 days. Next slide. The specimen collection times are critical to applying the high-sensitivity troponin algorithm. The 2-hour collection must be drawn between 90 minutes and 3 hours from the baseline draw. 4-hour collections must be drawn between 3 to 5 hours from baseline, and 6-hour collections between 5 to 7 hours from baseline. When he actually asked me to cover this at QMS, Chris Spidell asked the question, if you can't get a good specimen collected during the draw time range, what good is it? And I understand the question and even the frustration of meeting these very specific draw times, but even if one of the draws is missed or hemolyzed, other appropriately timed draws labeled with the correct draw time will prompt a calculated delta value and can provide that critically important information. I made the caveat of appropriately timed draws labeled with the correct draw time because I can tell you that in the laboratory we have had some instances of draws that were collected within the time limit but yet mislabeled with the wrong collection, in which we have been unable or have had challenges in calculating the delta value and reporting it accurately. So labeling of the specimen is also very important. Next slide. High sensitivity troponin will improve our management of chest pain patients with suspected acute coronary syndromes. Low-risk patients can be more efficiently identified and released from the ED without the need for unnecessary resource utilization, and more high-risk acute coronary syndrome patients will be identified so that early treatment with aggressive evidence-based therapies will improve outcomes. Next slide. I've only been using this test for less than a couple of months, but there are plenty of people within BJC who have more experience. If you have specific patient scenarios that you would like to ask questions about, I can put you in touch with BJH Clinical Chemistry Director, Dr. Mitch Scott, who was instrumental in the development of the algorithm that we're currently using within BJC, and he is very much more experienced in its use since BJH has been live with a high sensitivity troponin assay since summer of 2020. They are running their troponin on a slightly different platform that measures troponin I rather than troponin T, like our platform with Roche here at MBMC. But he is very knowledgeable about troponin interpretation, and if I can answer any questions for you, please feel free to call or email me, and I will either answer your question or put you in touch with someone who can. Thank you.
Thank you, Rhonda. Certainly change is not easy, but we appreciate your efforts. I'd like to thank all the speakers today, and at this point I would like to open up the floor for any questions. We have about 8 minutes or so for questions, so if you type your questions in, then we'll be able to address them while we're here. Alejandra, are you seeing any questions on your side?
There is one, but it was answered by Dr. Thornton.
Excellent. All right. Well, you can always reach out to us, and we'll answer as best as we can, and or forward the question to the appropriate person. I'd like to thank you for your time in attending today, and this isn't easy, but we appreciate your support. At this point, the meeting is adjourned. Thank you very much.